So let's talk about very briefly, my colleague and the presenter before talked a little bit about mineral metabolism and chronic kidney disease, but just to make sure we are all on the same page, here's a time course of disordered mineral metabolism in patients with chronic kidney disease. And we know early on there's an increased levels of fibroblast growth factor 23, a phosphaturic hormone, and that is the earliest alteration in mineral metabolism that's apparent in patients with chronic kidney disease. Even with GFRs as low as almost only 75, 80, we start seeing elevations in FGF23. We then realize that these gradually increasing FGF23 levels cause early decline in vitamin D or 125 vitamin D levels. This then frees PTH, or parathyroid hormone, from its feedback inhibition, which then leads to secondary hyperparathyroidism, which is commonly seen in patients with chronic kidney disease. And then finally, all of these changes occur long before we see increases in serum phosphate levels. And that usually becomes present as GFR declines to about 30 milliliters per minute. And that's when we start seeing this elevation in serum phosphate levels. And so this is how phosphate handling occurs. And on the left, you'll see healthy adults. And on the right, you'll see somebody, a patient who is anuric, who's undergoing hemodialysis. And so in patients with normal kidney function, we know that kidney excretion of X6-phosphate is what is primarily responsible for maintaining phosphate balance. But when kidney function is impaired, especially as CKD progresses to dialysis, the excretion of phosphate declines. And so this is why we don't see serum phosphate levels rise until really the GFR drops below 30, because really there's a reduction in tubular reabsorption, which is mediated by increased levels of PTH and FGF23 and phosphate itself. But in patients with stage 4 or 5 kidney disease, the dietary intake, or what we take in of phosphate, exceeds excretion. So treatments are necessary to keep phosphate levels within the normal range. So for example, in patients on hemodialysis, with a phosphate-restricted diet of 900 milligrams a day, we would still need to decrease phosphate absorption and increase fecal excretion of phosphate to maintain neutral phosphate balance. Hemodialysis on average, if it's high efficiency, and it may be different in Vietnam. So I know the prior speaker mentioned about 500 milligrams of phosphate per session is cleared or removed by hemodialysis. In this, depiction, hemodialysis on average can remove 800 to 1 gram of phosphate, let's say, per session. So leading to about 2,400 milligrams of phosphate in 1 week. But even in a phosphate-restricted diet, if you restrict it to 900 milligrams a day, for example, that means 6,300 milligrams of phosphate weekly. And if we absorb approximately 70% of that, that ends up being about 4,400 milligrams. So we would need to bind almost 2 grams or 2 milligrams to maintain neutral phosphate balance and not have this phosphate deposit in vessels and lead to positive phosphate balance. So to sum that up, if estimates are correct, then we would need to bind around 300 milligrams of phosphate a day in an anuric patient undergoing hemodialysis who's already on a phosphate-restricted diet, which we all know, and then everybody in this audience I'm sure knows, is quite difficult for our patients to restrict phosphate, given that phosphate is in many of the meats and vegetables that we eat. So what are the consequences of hyperphosphatemia? And I won't belabor this too much, and I know the prior speaker also spoke about this. And so we know that there are high risks of death and cardiovascular events in patients with chronic kidney disease. These are data from a landmark study by Alan Go that was published in the New England Journal of Medicine that showed that as eGFR declined from greater than 60 on the left to less than 15 on the right, that we see that the rates of cardiovascular disease as well as the rates of death increase substantially, especially as you get to GFRs less than 30 milliliters per minute. And so what are the reasons? And so the prior speaker also talked about these non-traditional risk factors that patients with chronic kidney disease have. There's something unique to our patients that puts them at greater risk for cardiovascular disease and mortality. And so serum phosphate is one of them. These are just 3 examples of studies that were done that show that as serum phosphate increases, whether it be in patients on hemodialysis in the top left, whether it be in patients with CKD on the right, or whether it be even in patients without chronic kidney disease, we see that elevations in phosphate lead to increased risk of cardiovascular disease and mortality. And so what are the different consequences of hyperphosphatemia, or why does hyperphosphatemia lead to this increase in risk of mortality as well as cardiovascular morbidity? Well, there's many possible causes, which include increased parathyroid hormone, inhibition of vitamin D, increased fibroblast growth factor. Here it says unknown mechanisms, but we know that FGF23 binds to FGFR4, a receptor on the cardiac myocyte, which can then lead to left ventricular hypertrophy and heart failure events, as well as just direct vascular injury, causing increased inflammation and vascular damage and vascular calcification, all leading to this increased risk of cardiovascular disease. And so here's data that were done that looked at different levels of PTH, calcium, and phosphate in individuals. And you see that in the very top, these are all individuals with PTH or parathyroid being high. And there's different things, there's calcium and phosphorus as well, but you notice that the highest risk of death is actually in patients who have high phosphate and high calcium. Individuals who just have who have calcium and phosphate in their target ranges actually are not at increased risk of death in comparison to those who have very high calcium or phosphate levels, even when their PTH levels are high. So basically saying that having high calcium and high phosphates in addition to high PTH is bad. Having high PTH alone, but normalization of calcium and phosphate at target levels leads to less morbidity for our patient population. And so this leads to calcium being bad as well. And so hypercalcemia is also associated with mortality in patients with end-stage kidney disease. These are frequency distributions and splines illustrating the relationship of serum calcium with all-cause mortality in patients undergoing hemodialysis. And on the left is the unadjusted, and on the adjusted is even after adjustment for even serum albumin. You see that as calcium levels increase, there's an increased risk of mortality. And so what do our guidelines recommend for us that we all follow? So this is what the KDIGO, or the Kidney Disease Improving Global Outcomes Data guidelines tell us from 2017. That one, we should be checking serum calcium and phosphate every 6 to 12 months. In patients with stage 4 CKD, every 3 to 6 months. In patients with stage 5 CKD or those patients on dialysis, every 1 to 3 months. And it could even be more frequent than that. This is how they recognize how important maintaining normal calcium and phosphate levels is. It also tells us that treatments of CKD-MBD should be based on serial assessments of phosphate, not just one phosphate alone. In addition, decisions about phosphate-lowering therapy should be based on progressively or persistently elevated serum phosphate. All of this makes sense. And then these are new guidelines that were updated from compared to the 2009 guidelines. In patients with stage 3A to stage 5D CKD, they suggest lowering elevated phosphate levels towards the normal range. And they suggest avoiding hypercalcemia based on data that show that hypercalcemia is bad for our patients, even in the setting of secondary hyperparathyroidism. And so what is KDIGO and KDOQI, which is the Kidney Disease Outcomes Quality Initiative that the National Kidney Foundation also gives out guidelines for? Well, so KDIGO says normal phosphate levels, normal calcium levels. And for KDOQI, even similar to that, but within